my colleagues. Today I have a collection of hepatobiliary system. This is the first session of hepatobiliary system. Candidate number 1, 35-year-old male patient presented with vague abdominal pain for 1 week, increased in the right upper abdomen. Go on.
Okay, sir. Okay, I am presented with CT of an adult patient having a vague abdominal pain and now increased abdominal pain in upper abdomen for 1 day. First, I will scroll down the images. This is post-contrast CT abdomen and portal venous phase. Now I'm going to scroll down and will look down for any obvious pathology. Then I will start commenting. Okay, the liver appears normal. There is mild strandings noted in the region of the pancreas, and some heterogeneous enhancement is also noted at the level of the body of the pancreas. Now I'm going downwards. The kidneys appear normal, spleen is normal. Now I'm going downward. There is also evidence of some fatty stranding and misty mesentery noted in the region of
Excellent.
the para-aortic region, basically. Now I'm going further down. Further, there is also the redemonstration of the same findings. I can see that there is some suspicion of filling defect noted in
Excellent. Excellent. Really excellent.
one of the branches. Now I will see its origin, whether it's from where it is originating. It is now I'm going to trace its location. It is now this. Now this is superior mesenteric artery, basically. Which
Are
is
you sure? No. One second. Are you sure this is superior mesenteric?
Sorry, let me trace it once again. Oh, okay. Now I will track down from the celiac axis. This is a celiac artery. This is superior mesenteric artery. I think this is one of the branches of the.
See. This is the superior mesenteric artery, and we are here in the left side. Go down. See?
So it is inferior mesenteric artery.
Yes, thank you.
Yes.
Thank you.
Yes.
And another point. Where is the diverticulitis? Where? What is this?
Diverticulitis.
Yes, where?
Where? Sir,
Which part?
This is transverse colon, I guess.
No, we are very low down.
I will. Okay, sir. So I will go down. This is descending colon. This is sigmoid colon. This is. Sir, I think. So can I see it on the coronal sections?
No. 1 second.
Okay.
What is this?
So duodenum?
No.
So where? Which part, sir?
This. Can you see my mouse? This one. This one.
No, sir.
Leave the mouse. What is
sir,
this?
I have left. Sir, I cannot see the mouse.
Okay,
see, sir, this
here.
is descending colon. Okay, sir, I have seen the
Descending colon. Follow. Down.
Yes, sir.
What is before or after the descending colon?
Sigmoid colon.
Okay, diverticulitis in this sigmoid colon.
Sigmoid colon.
What is the venous territory of the sigmoid colon? Superior or inferior mesenteric artery?
Inferior.
Okay, thank you, doctor, so much. This is the case of diverticulitis. See here, my colleague. Okay, my colleague, by the way, most examiner will give you axial, even all of them axial. Okay, and when you ask for something important for coronal or sagittal, they will give. but if it is important, okay? Here, the
Okay, sir.
diverticulitis. See, this is outside the colon, by the way. Look here,
Okay. Okay, sir.
outside. Okay,
Okay, sir.
see my colleague. See, air loculi outside the colon, and the
Yes, sir.
smudging of the vessel. Plus, this vessel is completely thrombosed. Thank you, doctor,
Thrombosed.
that you
Okay.
pick up this mild type of diverticulitis. You did very well.
Okay.
Thank you
Thank you,
so
sir.
much. You next candidate.
Hello.
Hello, request control, please.
Sir, I have requested remote control.
5 months, male patient with abdominal swelling and distension.
Okay, this is a frontal radiograph, abdomen of pediatric age group. There is a large haze or density occupying most of the upper abdomen, mostly predominantly on the right side. There is marked displacement of the bowel loops towards the left side and inferiorly. I am looking for any other visualized bones and other structures are remarkable. There is no bowel dilatation, no pneumothorax, no pneumoperitoneum. The visualized lung fields seem to be remarkable without any evidence of pneumothorax or pleural effusion. So, in summary, in this pediatric age group patient, the presence of a huge, large haze predominantly along the right side of the abdomen, extending to the left side, this is likely a mass. This is likely some soft tissue mass or tumor with the keeping in its location. It could be arising from the liver. However, other differentials would include masses from other viscera. However, I would like to take the history of the patient and also will compare with the previous imaging, also suggest ultrasound correlation of this patient for further characterization and further evaluation of this mass lesion.
What do you want to do next?
Ultrasound, I will do the ultrasound as this is pediatric age group and also 5-year-old child.
Excellent, doctor. Don't rush directly, my colleague, to CT or MR. Ask for ultrasound. If the examiner he will be happy at the first. But if he wanted to give you MRI, okay, you did the exact procedure, the good procedure. After X-ray is ultrasound. See, doctor, take this one. This is scrollable.
Okay, now this is scrolling. So first I will scroll. I think it's jumping mid-abdomen. Okay. These are grayscale images of the same patient. I can appreciate that and there are large loculated cystic mass in the right upper abdomen and also extending into the, I was looking mid-abdomen and also I am looking for this relation with the liver. So I think its image is not, yeah. A long left kidney, yeah. Kidneys in this patient seem to be, this is a long left kidney. This is unremarkable. I'm looking for right kidney, long.
So give me your differential diagnosis.
So first I need to rule out, need to see the right kidney because I need to differentiate it from the liver and the kidney, right abdomen and also abdomen. As this is, sir, I could not see the outlining of the right kidney.
Okay, يعني conclude what you see.
Okay, likely this is, as I could not see the outline of the right kidney, so likely this is originating from the right kidney multiloculated cystic nephroma. in this case. Other differentials in this case would be cystic Wilms tumor, or less likely differential in this case would be neuroblastoma. So I will inform the findings to the referring physician, and will suggest referral to the pediatric surgical team. Also suggest referral to the oncology, pediatric nephrology oncology MDT for further management in this case, besides staging workup for this patient. Thank you.
Go on.
Okay, these are contrast enhanced CT sections, axial slices of the chest, neck, chest, abdomen, and pelvis. I'm scrolling down. I could see. Now, I could see exact location of this mass. The liver is markedly enlarged in size, and it shows multiple variable cystic areas. Some of them, there is also peripheral enhancement in the surrounding some cystic areas. The right kidney could not be, both kidneys are normally excreting the contrast. So I changed my diagnosis from the renal tumor, renal masses, to the hepatic tumors. So my principal diagnosis in this case would be a hepatic hemangioendothelioma. Other differentials in this case would be other cystic lesions of the liver, likely cystic hepatoblastoma, or less likely possibility of hydatitis, but not in this case. So I will inform further the finding to the patient, and also will suggest referral to the pediatric gastroenterology oncology MDT. I also, in my routine practice, I would like to see the lung window to see any evidence of any intrapulmonary lesion or bone window. The note is also made of an thymus in this case. Also, I would like to see the bone window to see any changes in the bone if available. Thank you.
In your opinion, doctor, what is the most probable diagnosis? Hemangioblastoma or
hemangioendothelioma.
Hemangioendothelioma or hepatoblastoma?
Hepatic hemangioendothelioma.
And hepatic hemangio, look here. See, this is the venous. Okay, no, this is middle. Okay. See?
Okay.
How to differentiate between both of them?
Sir, hepatic hemangioendothelioma, these show gradual filling in the venous phase.
Okay, so
And
you see any gradual filling here?
I was suspecting in this one of the component. However, I would suggest further workup to rule out hepatoblastoma. Sir, was there any arterial phase available? I need to look for any arterial enhancement to say.
Unfortunately, no.
Okay, then I will suggest further alpha-fetoprotein or PIVKA2 correlation to rule out the finding of hepatoblastoma, and MRI may be helpful.
Okay.
For further testing.
What is from a pathological point of view? What is the difference between hepatoblastoma and hemangioendothelioma?
Hemangioendothelioma, these are related to the blood vessels, likely the name shows, and the hepatoblastoma, they are originating from the hepatoblasts, hepatic cells, and they take blood supply from the hepatic artery.
Okay. And yeah, you mentioned hepatoblastoma.
Yeah, hepatoblastoma and other differential hepatic hemangioendothelioma.
Yeah. What is from a pathological point of view? What is the difference? You told the endothelioma is a vascular. Okay. And hepatoblastoma.
Yeah.
What about the hepatoblastoma?
They originate from the hepatocytes.
Okay. What else?
Also, they differ from the characterization of enhancement pattern. The hepatoblastoma, they do enhance in the arterial phase as they take blood supply from the hepatic artery, and the hepatoendothelioma, they usually show gradual fill-in, as the hemangiomas in the elder population.
Thank you, Dr. Abushra, so much. You are brilliant. Really, I'm so impressed. Really, your style is amazing. You are a June candidate or October candidate?
Sir, I'm October candidate.
Really, your style is amazing. My colleagues, Dr. Abushra's style is an ideal style for passing Viva. Dr. Abushra, you are very self-confident. I ask her, by the way, my colleagues, I ask her very difficult questions, many, and she is stable. She didn't hesitate. She said what she know. Despite at the end, she didn't. Yeah, by the way, I must give you the highest mark. Despite I asked her very difficult question at the end, but she didn't hesitate. She didn't afraid. She told what she know. This is a case for differential diagnosis. It may be hepatoblastoma, hemangioendothelioma. By the way, this case is hepatic because the age is very young, 5 years, 5 months. This is a hepatoblastoma. Why? There are no peripheral enhancement, nodular enhancement. Unfortunately, we didn't have arterial or blade to judge about the filling closing iris sign. This is a mass or mural mass, by the way. Okay, my colleagues, the difference between hepatic hemangioendothelioma is a vascular tumor, completely vascular spaces, vascular tumor. But hepatoblastoma is a malignant tumor of the liver, the most common malignant tumor in the liver in the children below 4 years old. Okay, this is an embryonal tumor. But the examiner, I think, will not ask you this very difficult question. I just wanted to show you to how extent Dr. Bushra has a very, very good self-confidence. And even whatever the examiner asks you, don't hesitate. Some examiner wanted to assess your personality. When I ask you something, you will hesitate, you will slur, any signs of he look why he opened the camera in the exam, by the way, because he always looking at your eyes. He's searching your body language. Is this doctor be worth to be added in our NHS? About his personality, when our radiologist face any urgent or any unexpected situation or case, he will collapse or he will struggle and try to find a diagnosis. All of this question, this 1 hour Viva, the examiner are searching inside your personality and your knowledge. Thank you, Dr. Abushra, so much. Really, I'm so impressed.
Thank you, sir.
Next candidate. Next candidate.
Yes, sir.
Request control,
Yes, sir.
please.
Sir, sorry, I'm unable to. I'm at work.
Okay. 60-year-old male patient presented with epigastric and lumbar pain, fever,
Okay, sir.
nausea, and vomiting.
Okay, sir. Okay, sir, I am provided with the out of phase imaging, T1 out of phase imaging, and I could.
Let's see here or here better. Okay. Just
Sir, I'm provided with T2 weighted images of a patient who presented with nausea, vomiting, and lumbar pain. Sir, please scroll it for me. First, I'll look at the entire stack, then I'll give my opinion. Patient presented with lumbar pain, and I could appreciate that the gallbladder is diffusely thick-walled, and adjacent to it in segment 4A, I could appreciate a hyperintense signal with liver parenchyma. I want to see it on the post-contrast diffusion restriction images. Yeah, this area is hyperintense on T2 sequences, FAT-SAT, with the peripheral, central, it's hyperintense, and peripheral, it's slightly low. I would like to see the sequential post-contrast imaging to characterize it further, and I want to have a look at gallbladder once.
See, we have MRCP. What happened here?
Sir, on the MRCP, I could appreciate multiple areas of narrowing, maybe in the
Excellent.
between junction of right and left hepatic duct, at the junction of right and left hepatic, and in the main CBD, I could also appreciate, I think there are few filling defects. I would like to confirm if they're artifactual or they're tiny calculi noted within the distal CBD. There is no abrupt. No, they are not. I think there are not no intraductal calculi. There is just the beading appearance and multifocal stricturing noted within the intra and extrahepatic bile ducts.
No. See, the extra is completely normal.
Fine.
What
Yeah,
happened
it's
here? Here, what happened?
Sir,
Correlate. See, doctor, one second. You see our pathology here, and you describe it well.
Yes, sir.
When I give you something else, don't destroy the previous finding. Build up
Okay,
on
sir.
it. See,
Okay, sir.
there are narrowing here, and what about this? What is this? Is this the same? The same? Is this one? Looks like yes. So what happened here?
Sir, so this is a mass closely related to the bile ducts.
Okay. Again, could you repeat this phrase again? What happened?
Sir, it is closely related to the biliary ducts, and I'm thinking in the line of cholangiocarcinoma.
Excellent.
But I would like to see the enhancement pattern before.
Excellent. So conclude, please, my doctor. Conclude.
Sir, I could see a mass in the liver segment 4A in the within the biliary ducts, and likely with mild capsular retraction, and likely representing with intrahepatic biliary ductal dilatation as well, likely representing a cholangiocarcinoma.
There are no retraction, doctor. No obvious retraction. I couldn't see it by. Okay.
Okay, sir.
And this mass related to?
Biliary ductal system, cholangiocarcinoma.
So most likely to be?
Cholangiocarcinoma.
If we give contrast, by the way, no contrast images available in this case, but if we give contrast, could you describe for me what will happen?
So it will show the centripetal enhancement, the gradual fill-in, just like an hemangioma. But it's not nodular.
No. See, gradual enhancement. This is more characteristic, and you confirm like hemangioma. No, don't say it like this anymore. Okay, hemangioma is a characteristic gradual enhancement. What is the name or the process of enhancement of hemangioblastoma? One word.
Cholangiocarcinoma.
Sorry, cholangiocarcinoma. Sorry.
Sir, it's centripetal.
No. What else?
No,
not centripetal at all. This is again, you are talking about hemangioma.
Sir, I have read that cholangiocarcinomas also have the centripetal enhancements. No.
See, but the most common cholangiocarcinoma take enhancement or contrast in arterial, yes or no?
No, on delayed phase.
Okay, so cholangiocarcinoma will show a delayed
phase enhancement.
A delayed enhancement. This is the buzzword and the most common term related to enhancement of cholangiocarcinoma. Okay? Delayed
sir.
enhancement. Why? What is the cause? What is the underlying pathology? Why cholangiocarcinoma
Uh,
take يعني in delayed?
Sir, because there are biliary channels, so there is delayed excretion in the maybe in the cholangios. First, the liver will take up the contrast, and then
Okay, but because it is hypovascular, very easy.
yes, sir.
Hypovascular.
Okay, sir.
Any hypovascular lesion, okay. And I think cholangiocarcinoma because when it causes retraction, it indicates that it have some fibrous stroma. So
Yes, sir.
overall, the cholangiocarcinoma is hypovascular, at least in relation to the nearby liver parenchyma. Thank you, doctor.
Okay,
You
sir.
did very well. Please use the common buzzword that related to the case. I will tell you one story, one something يعني not good for- about one exam for me. The examiner asked me about the cavernoma, and I know that it has many names. I told him one of the rare names. He become very angry. Despite I'm sure this is correct name, but the name that I use is not familiar to the examiner. So it is better to use the most familiar information about your case. Okay. Another thing, sometime we see a focal lesion here, and it take early early arterial contrast uptake, and then wash out. Okay, my colleague, and then it shows some foci of delayed enhancement. Okay, this is a mixed type between HCC and cholangiocarcinoma. It's called HCC containing cholangiocarcinoma. You may or may not find some retraction of the capsule. Okay, but I think it is beyond the FRCR exam. But I just, by the way, mention. Thank you, doctor, so much. You did very well. Next candidate.
Assalamu alaikum, sir.
Salam, request control, please.
Sir, I don't know why for the last few days the requesting option is not showing up at the top.
Okay, it is from the option, no problem. This 50-year-old female patient presented with abdominal pain.
Okay, these are CT abdomen images in portal venous phase in a 50 years old female patient. I will take a moment to go through entire stack. Then I will start commenting. In this post-contrast enhanced images, I can appreciate that there are faintly hyperdense lesions seen in the periphery of the liver. Some
Okay,
hypodense areas are also seen in the liver parenchyma in the periphery. There is
please better look here because this is the
yes,
arterial.
these are arterial phase images, and I can appreciate that multiple arterially enhancing lesions are seen. They are rounded in configuration. Most of them are peripherally located, and some of
Okay,
them have vessels reaching up to the periphery of the lesions. Sir, sorry.
yes, okay, you are right. Go on.
Okay. At this point, arterial enhancing lesions rounded. I'm thinking in a 50 years old patient, I'm thinking in lines of that it could either be metastatic deposits, hyperdense mets of some known primary or unknown
Okay,
primary, or these can be hemangiomas. I would like to see the previous imaging, and I would also like to see the washout
see,
pattern on the
one
portal.
second. Yes, 1 second. This is the arterial. So don't ask for previous image. Did you finish this study?
No, sorry.
So let's see the venous happened here.
In the venous imaging, the lesions are not showing washout. The residual parenchyma is hyperdense, but the lesions are also hyperdense.
Okay, let's see the delay.
And in the delayed imaging, They have become isodense to the parenchyma.
Okay.
I think that these might be hemangiomas.
Are you sure, doctor? Doctor, see, in the arterial,
Hmm.
marked hyperenhancement. Then less here. Okay, it didn't show a significant washout, but the contrast is not increasing. Okay,
Contrast is not increasing, yes.
and in the delayed, no contrast is not increasing. It is about to be like the
Rest of the
similar
time.
to little bit similar to the liver parenchyma, despite it is slightly hyper. So, what do you think? What is your opinion?
Sir, I think that they are, I don't think they are malignant because
Okay, this is right. So you are dealing with aggressive
hmm,
or
benign,
non-aggressive benign.
non-invasive, non-invasive.
Give me some differential diagnosis.
So differential diagnosis based on these appearance can be adenomas or hemangiomas.
Okay,
Uh, Less likely to be hemangiomas because all of them are showing very similar characteristics of
what
enhancement.
else? What else?
Uh, Other options can be
What is the three benign hepatic lesions? There are three, only three. Hemangioma and eoxycloid. Adenoma and the last one, we don't know other than these three. What is the last one?
the last
What is
one.
what is the lesion that always we differentiate from adenoma?
Sir, I don't remember now. I only remember hemangiomas and adenomas.
Yes.
Thirdly, which will take enhancement and washout and delayed. They are sometimes they are mets, but the appearance don't look like mets.
What is your
So
next step?
next step is I would like to compare with the previous imaging. If
What else? No previous. What else?
then I will advise follow up in 6 months time with to
But
see what
what
is the
the clinician want a definite diagnosis. Do you have any radiological examination with
Yes,
contrast
I can
with
do MRI imaging.
which type of MRI?
In phase, out phase,
Okay, what else?
and three phase contrast enhanced study,
Only three phase?
four phase.
What is the the fourth phase? What is the name of the contrast?
It is okay. I think I'm dealing with fibronodular hyperplasia. Fourth
Okay,
phase.
and you should request which
I should
MRI
request
contrast?
Primovist, hepatobiliary
Okay,
specific agent.
see here.
This is T1 contrast enhanced image in the arterial phase. They are enhancing very well defined lesions located in the periphery. They are mostly rounded and variable
See
in
here.
size. In the portal venous phase, I can see that the lesions have become isointense to the meaning of the parenchyma. I would like to see the delayed phase.
I think here this is not hepatobiliary specific contrast, by the way, but give me a final differential diagnosis.
Sir, final
See
differential
here.
diagnosis. I think this is hepatospecific contrast, and they are taking up the contrast.
This one, let's see it. No. See, by the way, hepato-specific contrast, you can't see the kidney like this, like this.
Hmm.
Okay. In hepato-specific contrast, what happen? You will see the liver is very bright because it is taking contrast. Okay. And other organs like delayed. Exactly. You will see both kidneys completely non-enhanced. Okay.
Hmm.
Let's see here. This is not the delayed one of hepatocellular specific. I think
Okay,
here
completely.
no hepatocellular specific. So give me a differential diagnosis, please.
Sir,
See, in the
finding
arterial, see, let's revise. In the arterial, marked enhancement. Okay. Then in the venous, this is the
iso.
venous. Okay. ISO, almost ISO. Okay, and in this one, suppose this is delayed ISO. So, what is your differential diagnosis? And by the way, they are multiple benign. What's your final diagnosis, doctor?
Imaging findings of contrast enhanced CT and triple phase MR imaging are consistent with multiple hepatic fibronodular hyperplasia lesions.
Excellent. If I give you hepatocellular specific phase, after how long do you want this phase? How many minutes?
Sir, is it 15 minutes? I think
No, 20. For prime
20.
vest, it is 20. Okay.
Okay.
Second question. Why FNH, focal nodular hyperplasia? What is the appearance of FNH in hepatobiliary specific phase, delayed phase? What is the appearance?
It is iso to the rest of the parenchyma.
Again, doctor. FNH contain hepatocyte or not?
No, sir, it doesn't contain.
Are you sure?
It
Are you
contains
sure?
Kupffer cells, I think.
Yes. See,
It
from
contains
the name,
Kupffer.
focal nodular hyperplasia. So it contains hepatocyte and von Kupffer cell, both of them. Okay. So it will uptake the hepatobiliary specific contrast or not.
It will uptake hepatobiliary
Okay,
specific.
so it will enhance or not in the delayed phase, delayed hepatobiliary specific phase.
Sir, it should enhance.
It will enhance. Okay,
It
correct.
should enhance.
Okay. The opposite is adenoma. Adenoma will enhance or not?
No, it won't enhance.
Why?
Won't.
Because it doesn't contain
The normal hepatocytes.
Okay. This is the sequence. Okay. And here what happened? This is not hemangioma. Here in arterial, complete enhancement. Your first differential diagnosis, number 1, HCC, number 2, FNH. No hemangioma. Hemangioma must be peripheral, discontinuous, not complete enhancement like this. Second, my colleague, I can from this image expect the nature of this masses. Why? Look here, no focal contour bulge. Look here, the mass is here. It doesn't compress the arteries, so no mass effect. Here also the same. Here the same. So this is multiple benign looking masses. See here, no any infiltration for the gallbladder. So this is benign. Oh, I should search in my mind. What is the benign hyper-enhancing arterial multiple focal lesions? Adenoma or FNH? So I should revise the venous. Oh, doctor, it become nearly similar to parenchyma of the liver. Nearly similar, ISO. Okay, so FNH in top of my differential. In delayed, the same. I will conclude how to diagnose FNH. Only it is hyper enhancing in comparison to the liver parenchyma and arterial. Then it almost follow the liver parenchyma. Follow the liver parenchyma. Okay? And when you give here prime of hepatocellular specific and contrast, it take enhancement. Okay? Why? Because it contain hepatocyte. Okay, doctor?
Okay, sir.
But adenoma and the metastasis didn't take contrast in the delayed hepatocytic phase. The hepatocyte phase in prime ovest is 20 minutes. In the older contrast, it was about 60 minutes and 120 minutes. This is according to the quality of the contrast and the ability of uptaking by the hepatocyte. But now it is 20 minutes. By the way, when you have a suspect an injury of the biliary duct, tell the examiner, I will wait, I will give a Primovest, and I will wait 60 minutes, 60, 60. Why? To give a chance, a good chance for excretion of the contrast. If the biliary, see, if the biliary tract here injured, what will happen? The hepatocyte will uptake the contrast, and then after uptaking it, it will excrete into the bile duct. Okay, and then minute by minute, after 20, after 30, after 60 minutes, considerable amount of the Primovest will be seen outside the liver and outside the biliary tract. Okay, because this question I search all Google, all radiological site, I didn't find this knowledge, but I listen this point when I was listening at Dr. Khan lecture, and it is very important, really, by the way. When you suspect a biliary tract injury, ask for post 60-minute delayed phase post Primovest. Thank you, doctor, so much. Next candidate. Next candidate.
Actually, the two following candidates are not around right now. We
Okay.
will go directly to candidate number 8. Please go next.
Assalamu alaikum.
Salam. Control, please.
Sir, I cannot hear myself.
Okay, doctor. Doctor, there are echo in my voice. I listen myself twice. Could you
Sir,
switch
I am on mobile.
mobile?
I am on mobile.
Okay, no problem. This is a 60-year-old male patient presented with right upper quadrant pain and deep jaundice.
Okay, I'm provided with multiple ultrasound images of a patient in which I can appreciate marked dilatation of central intrahepatic biliary channels, and gallbladder in the valuable images is distended and is filled with thick membranous bile, and CBD is markedly dilated as well. I would like to see the pancreas, whether there is obstruction at the distal part of the CBD. And in the pancreatic region, I cannot definitely appreciate the pancreatic normal echogenic parenchyma. Rather, the dilated CBD is visualized, and I'm suspecting that the distal biliary obstruction with marked intra and extrahepatic biliary channel dilatation along with distended CBD containing the membranous bile are concerning for ampullary or periampullary pathology, which leads to obstruction. I would like to see the pancreas on ultrasound in detail to rule out any mass in the uncinate processor head or in the duodenum near the ampulla. Next, I can go for...
Yes.
I cannot appreciate any enlarged lymph nodes in the region.
Yeah.
And the stomach.
See, doctor,
Yes.
don't take long time in ultrasound. You pick up the finding here, okay? And you exclude very important thing that there are no pancreatic pathology. So my advice to you to jump to the next step. Ultrasound is a limited study. Okay?
Okay.
What is your
Then I will go
Yes.
CT abdomen with oral and IV contrast. Okay. I am
Okay, but
provided
see,
with
doctor,
multiple MR images.
also my advice for you for biliary system especially, it is better to talk about MRI. Okay? Why? Because
Okay, sir.
see here the pathology mainly in the biliary system. Okay?
Okay, sir.
This is not wrong, by the way. You are not wrong. But could you think if there are flat skin tumor here, we will not detect at all by CT? Never.
Yes.
So you can tell the examiner, doctor, as it is a biliary system pathology. In my routine practice, I will transfer patient to MRCP and MRI. One exam. Okay. Although CT may be also of value, but less than the MRI. Like this, the examiner will be very happy that you know the exact what you are requesting for which pathology. Yeah. Okay.
So I'm provided with coronal T2 weighted images in which this is further confirming my findings of intra and extrahepatic maldilatation of the biliary channels, and I can appreciate a hypointense linear focus in the distal CBD just above its simple reopening. This
Look here, better. What happened?
The CBD is dilated, and I can appreciate narrowing just at its distal end. A hypointense focus is noted. The images are quite blurred right now.
Okay. You see? This is the CBD.
Okay. CBD is dilated, yes. And there is hypointense, isointense mass lesion, which is noted just anterior to
I will
the
help you. What happened here, Stacy? What happened here?
Sir, there is abrupt cutoff of the distal CBD, which is depicting.
No, look again. Look again here. What happened? This is obvious. Look at the biliary system. Look at the biliary system as a whole. Generally, what happened here?
So there are multiple small areas of alternate areas of small dilatation and narrowing with irregular walls, and this is extending to the entire CBD as well.
Yes.
And so this patient is suffering from sclerosing cholangitis, which leads to the BD apparent.
Okay, look here again, please. Look. What happened?
There, the dilatation.
Yes.
Sorry.
In sclerosing cholangitis, we are worried about something.
Okay. Sir, there can be a small biliary small collections or abscesses. Also, the small collections are also noted. Okay.
Okay. What is the association? Some association with sclerosing cholangitis?
Sir, this can later be associated with first of all infections, multiple infections, and second the mass.
No infection in sclerosing. Sclerosing is an autoimmune disease.
Okay, sir.
So look here. Look at the middle, please.
Sir, there is a isointense lobulated mass which is noted just in relation to the medial part of the
This is not
duodenum.
mass, doctor. This is not mass. This is a structure. This is organ. What happened here? Here.
There, this is the region, anatomical site of the.
Here. What happened here for this organ?
Sir, this is pancreas, which is dilated, showing marked dilation of the pancreatic duct, and pancreas is diffusely bulky and hypointense with irregular peripancreatic fluids. So this is associated with the pancreatitis.
Okay, and, what type of pancreatitis? What type?
Pancreatitis, if it's an autoimmune disease, then it's an autoimmune pancreatitis, resulting in marked dilation.
What else you should exclude in case of autoimmune pancreatitis and sclerosing cholangitis? What else? There are very common syndrome.
Sir, this is associated with bowel disease like ulcerative colitis, I guess.
Okay, what else?
Ulcerative colitis.
But ulcerative colitis not associated at all with autoimmune pancreatitis, not common.
Okay, sir. Sir, I cannot remember right now.
There are an autoimmune disease cause fibrosis.
Okay.
What is the name of it? Retroperitoneal
fibrosis. Okay.
Yes,
so these are spectrum. Yeah.
No, see, we are searching no
The
retroperitoneal fibrosis. What else? What else? IgG4. IgG4. What mean by IgG4? See, this is a pancreas. Yeah.
That IgG4 related diseases that include fibrosing mediastinitis.
Yes, yes. Look here,
Pericarditis.
sausage shape pancreas, loss
Okay.
of its digitation, and bulky. Bulky.
Okay.
See? There are dilatation. See my colleague? There are dilatation, beaded appearance of the biliary, intrahepatic biliary radical. So it was a case of IgG4 related sclerosing cholangitis and autoimmune pancreatitis. Thank you, doctor, so much. Next candidate.
Yes, sir. Candidate 9.
I'm sorry, I was candidate 7.
Okay. Candidate 7. Request control, please.
I'm so sorry, I can't request control.
Okay. 80-year-old female patient presented with abdominal pain post cholecystectomy. She has abdominal pain, yeah, 3 years after cholecystectomy. What do you think, doctor? Okay, you request control. Hello? Hello? Okay. Use the R. Can use the Hello, doctor. Hello. Hello.
Sorry, can you hear me?
Yes, raise your voice, please.
Yeah, so this is a CT abdomen with contrast, with IV contrast. So the is it post cholecystectomy, right?
Yes. Please raise your voice.
Okay. So you can see the cholecystectomy clips, and there is adjacent multiple pockets of collections seen at the gallbladder fossa, with adjacent stranding. The pancreas appears atrophic. I'm trying to go through. Okay. Okay, so these collections appears to be larger than expected for post-operative changes. There is no internal enhancement.
Doctor, please raise your voice.
Okay, there is no enhancement. Okay.
1 second, leave the mouse. 1 second. Raise the voice, okay?
Yeah, okay. I can see the images.
What is the finding? What is your finding?
So, in the post-operative patient, I'm concerned of either there's leakage
Okay, or
at the foci within this collection or an infection
okay.
On the patient.
Look here. What is
There
this?
is focus, gas focus within one.
Okay. Do you want to ask about any history for this patient?
Any fever or
Yes,
raised
she has fever. She has
markers,
fever.
yeah. So most probably this is inflammatory collections.
Okay. See, what is this? Peripheral
enhancement, yeah.
Okay, so what's your diagnosis?
Post-operative, yeah. Infected collections, abscesses, okay, abscesses.
Okay, what's your next step?
So I will
for abscess. What would you do?
I would inform the urgent refer to the upper GI team and inform the radiology.
Okay, for
radiology for drainage.
Okay, thank you, doctor, so much. Oh, you did very well. See my colleague. I will mute you, doctor. Sorry, because you have some noise. Thanks so much, your candidate, our candidate 7. Thank you really for your participation. See, this is a post-cholecystectomy. What happened here? Collection. So either leakage or infection. She told me she are searching for air loculi, this one. And you see, my colleagues, there are some peripheral enhancement. And you should ask the examiner, doctor, is this patient has fever? The examiner will not ask you, doctor, do you want to any history? He will not ask you like this. Okay. The most, I think the most reliable point here in diagnosis of abscess is the history. The patient has fever after the surgery by 3 weeks. Okay, this is abnormal. The patient after the surgery was good. 1 week, 2 weeks, then he developed a severe fever. Okay, and right abdominal pain. So this is abscess until proof otherwise for interventional drainage by, see? Drainage by what? Either ultrasound. I think ultrasound here is not difficult. Anyone know how they drainage this abscess or this specifically? The approach? How many approaches they have? Anyone know? I will tell you. They are to approach the lateral one from here and the anterior one. Okay? The lateral and the anterior one. Either they use they insert the needle anteriorly from here or laterally from here. Either CT guided or ultrasound guided. Each one of this approach has its specific indication. Okay, my colleagues, they will put portacus and it will be drainage. Thank you, doctor, so much. Next candidate.